Well, welcome back, everybody that was here earlier today. We're gonna call the meeting to order. It's 5:30. And Shelley, would you like to do the land acknowledgement?
I would. We will teach to the Tlingit, Haida, and Tsimshian people. We respectfully acknowledge them as the original inhabitants of Southeast Alaska. Bartlett Regional Hospital is located on the homelands of the Akwaan. We are grateful to provide services in your ancestral homeland and be part of this community.
Thank you, Shelley. You can do roll call. Here.
Dr. Rasker,
Here.
Lisa Peterson,
Here.
Al Geiger,
Present.
Roger Jones,
Here.
Kelly Deering, here, Deb Johnston,
Here.
Eddie Sullivan Brooks. And we do have Wade Bryson and Dr. Mulder.
Here. So approval of the agenda, is there any agenda changes today?
I move to.
We'll check that. Second that. Seeing no objections, the agenda is approved as is. Do we have any members of the public that would like to speak today? Anybody online? I do not see anybody in the room. Seeing no public participation, we move right down to the consent agenda. Can I get a motion to approve the consent agenda?
I move that we approve the consent agenda.
Second that. Any discussion? Seeing no objections, the consent agenda is approved. I guess. All business, we'll turn this over to Kim.
Thank you, Mr. Chair. For the hospital capacity update, we have one VRH employee with COVID, one wildfire port employee with COVID, and we also have one COVID patient in-house, and we also have one patient that's currently ventilated on a respirator in-house that is not COVID related. Patient days for CCU for July were 93, med surg 442, MHU 288 with a current census of 8, OB 82. Newborn nursery 68, the ER saw 1,134 patients last month, and RRC has a census of 9. We currently have 3 long-term care patients waiting in-house, 2 assisted living patients waiting for transfer, and 1 subacute rehab. And I will let Kim Stout give her census for Wildfire Port Home Health and Hospice with the report, and I'm happy to answer any questions.
Any questions for Kim? No questions for Kim. Thank you, Kim. Moving on, I'll turn it over to the Madam Vice President for the CPO search.
Everybody knows we're in the final stages of the search. We completed 1 interviews with 1 candidate. We have another one tomorrow. Will be with us all day tomorrow with a number of groups tomorrow. We will talk to him on Thursday morning. After that, we'll have a final candidate the following week. When we've completed that interview, it's Friday the 6th. We will roll directly into board meeting for deliberation for selection of our candidate. It will be an executive session. We'll announce the final candidates, not at that time, I realize, but when the candidate has accepted and we begin the process. Any questions about where we're at? A number of you have been, almost everyone was at this morning's interview. So you're aware of what the process looks like. But if there's any questions.
I have a comment. I just want to say thank you to Deb and to Chad. We set deadlines and we rocked it. So thank you guys for pushing us forward and making this a timely process.
So I have a question. I'm not really sure 100% if this is the appropriate time to ask the question, but I'm going to do it anyhow. We've had a lot of stakeholders that are going to be meeting with the candidates. So if we roll right into deliberation after the last candidate, when will we, as a board, see what our stakeholders said, our people from the city said, our staff has said? I really want to see their comments before, I feel comfortable with everybody making a decision. So do you know when this week?
I'm gonna defer that to Chad. He has created the venue, the medium for comments, and he can explain his timeline.
Okay, thank you. Chad?
For the record, this is Chad, and I want to make sure I give kudos to Erin. She actually created the form, but yes, we're using Microsoft Forms to solicit the feedback from staff and members of the public, whoever attends any of these events. So in terms of going into the last interview, we're just communicating with those individuals, all those stakeholders, to make sure that they know that the last interview is very time sensitive, that the board is expecting to make a decision after that board meeting and to put in their notes and their information in the day of that meeting day, which would be September 5th. And then the board will have their meeting September 6th. So after that board meeting, you should have all the information. It's all being aggregated on the back end. So it's, as long as it's automated. And then if we have any paper, so far, I don't think we've had anybody fill out any paper documentation to provide feedback. So it's just a matter of providing the electronic version.
So Chad, will we have that consolidated information the night before, at the end of the process on Thursday?
That my goal would be to give that to you at the end of the night on the 5th, probably later in the evening after we have time for the meet, greet, et cetera. To go ahead and get that over to you so you can review it, ask you to have the board meeting on the 6th.
Will that,
Dr. Jones?
So I was wondering if there's any way to get I mean, I looked at their stakeholder groups, I see our stakeholder groups being senior leadership, I see our staff stakeholder group, I see the city being a stakeholder group. Is there any way we could kind of get a summary or someone that would be a representative to kind of give us that information? So I think it would help me to make certain that, help me with the decision and make sure that we're all, that, really, I mean, I think, a lot of people just put a lot of energy in there, and I want to make certain that they really know that we have reflected. I don't know how helpful it's going to be for me to get people that filled out just this form. I really wonder if there's a way to kind of aggregate that data in the various stakeholder groups as one may see.
So I just want to make sure I'm gonna encompass the question here, okay? So are you asking for a stakeholder person from each of these groups to come in and speak with us at that board meeting? Or are you asking for Erin to give us a summary of everything from the writings, along with seeing all of it in context?
Personally, I would like a summary from the different stakeholder groups. I think one thing that was brought to my attention from our previous search is that some people felt that we did not hear what they had to say. Not that it would change our opinion, but they felt that we didn't hear what they had to say. And I just want to make certain that when we make this decision, that we thoroughly understand what each stakeholder group says are what they perceive as the strengths or weaknesses of the individual candidates. And so again, I think that for me, that's hard to get out of a bunch of comments. But again, I'm interested in, what is, and so I don't know how to do that, Chad, or if that's a possibility or what other board members think. And,
my only comment with that is, particularly with the staff, I'm not sure who would the staff has a variety of opinions in general. So I'm not sure a single person to represent, say, a department or a segment of the staff would give us a clearer picture than if and I guess the question for you is, Chad, do we have the capability of segmenting the feedback by stakeholder group? Or is there something?
Yes, the short answer is yes. The form is very simple. It's the date, it's their name, it's the candidate name that they were talking with. What function they met them at, was it the town hall? Was it the management team meeting? Was it the public meet and greet? And then one simple question with an open text field. So yes, we'd be able to by name, put them into kind of a category or a bucket, so to speak. So all of those comments would be reflected group by group. And that should be pretty simple. It doesn't summarize it, but it would aggregate it into at least sections.
Well, reflection, I think this is a very good idea. Now, obviously, we don't have time to listen to 600 and some people's individual comments. And so then we select some people and maybe we don't have the exact representative person for each group, but I think it's such an important decision. I think it would be important to listen very briefly to what as many people as we've got time for that represent as many entities to hear what they have to say. And I don't know how we do that, but I'd like to hear what the union says. I'd like to hear what some medical staff say. I think that's important.
Aaron, I saw you talking to Chad. What's your thoughts on this?
Well, I was sharing with Chad that the Microsoft Forms does do some automation for us. So for example, it'll populate word clouds based on common themes or notes that staff put in. So if communicate, like certain words emerge, it'll display visuals for us to show us, hey, a large number of people put in this particular word or phrase, and that'll allow us to dig a little bit deeper. We could certainly do the filtering that Chad suggested. I think at this point, since the stakeholder process is already underway, one of the things that we could do is really strongly emphasize that the staff who have meetings set aside, and particularly like union leadership and city leadership, so you get your stakeholders captured, take the time to follow through and so they had the opportunity to have a one-on-one meeting. We need to make sure that we capture their feedback now in writing. So I think that's the key for us, is to make sure they follow through. So we've been emphasizing that with staff pretty heavily. It's on our intranet. We've been rounding. I don't know if Chad has another suggestion, but we really need folks who attended meetings to take the time to share their thoughts in writing.
Chad?
In addition to that, I wanted to note that we got compressed into a time frame that ends on September 7th. And the reason for that is because I understand we have several people out on vacation for multiple weeks after that, which would have, if we had delayed the candidate process, it would have pushed us into October. So keep in mind, if we want to have a meeting that would require public notice, we would be pushing the candidate selection process out multiple weeks with the possibility of losing candidates. I don't know how comfortable people with that.
Yeah, I appreciate you saying that, because I thought the main board meeting to make final selection was September 7th, but it's not.
September 6th, we changed it.
Oh,
We
okay,
just moved it one day.
that's okay. Thank you. At least I'm not having a hallucination that I.
So I know this is and I think this is something that we should have the board talk about here. And we can just ponder this again, but is it possible to have a representative from each one of the stakeholders come in and give us a 5 or 10 minute synopsis of what their group feels, along with also us having the comments? And I know that'll make our 6th board meeting go, maybe half hour longer than we had to. Again, this is such an important decision.
We could do that possibly. We could also look to have them write maybe some sort of a summary memo or note or letter to the board summarizing their feelings. Again, I don't know what the availability of the staff is, so the answer is yes, we can do whatever you want. Whether or not people can make that time frame, I don't know.
Could we give them the option, Chad? Could we set aside a half hour? You identify who the groups are, and then they can have the choice of whether they want to do something in writing or come to a 5-minute in person.
Yeah.
Dr. Malter, eh, are you prepared to provide the feedback that came from came out of the medical?
MedExec is gonna have a chance to meet with all three of your candidates and will, if we have strong comments, we'd be happy to present them. Otherwise, we can be writing. Otherwise, we'll just say that we thought all three of them were great.
So
that.
the stakeholders that I see as senior leadership, I think, I'm sure there's more, please don't, I think as far as our clinical staff, which I would assume would be represented by the union. I think the city's a stakeholder, and I believe that Med Staff's a stakeholder. But there may be more, but those are the ones that I see right there that would be it's off the top of my head that I would really like to get something from.
And I believe those are the four groups that we actually asked to participate. So,
And then the town hall.
Yeah. And the town hall and the employees too.
Yeah, I wonder if it would be possible to specifically reach out to the three main primary care practices. I'd like to know what Valley Medical.
I think that would come through the midst.
Well, yeah, the med staff would speak for the med staff, but I'm thinking about these. Well, yeah. I'd like to know what those practices.
So they are gonna be represented, yeah.
Through the chair, I think Anita sent out a notice where folks could meet. But at least at the medical staff meeting, which is where we anticipated that folks would meet the first candidate, only MedExec people were there. So I'm not positive that representatives from three practices would have even met all three candidates.
Thank you.
And there's good representatives. You got Alex from Family Practice, you got Luke from Valley. So we're still.
Okay, thank you
It's
guys.
very reasonable, and the only other team that I would add was that we did have everyone, our middle management team, so our directors and management team, I would add them as well, I think that's, so.
Thank you. Thank you. Karen. Thank you. Yeah, do you have any more on?
They don't.
Yeah, organizational design.
Thanks, we've had this conversation over the last couple of months, and so wanted to give you guys just a very brief update as to our status. So the last time we met, I had mentioned that we would be meeting with the senior leadership team to discuss, kind of their thoughts on organization design. We had to make sure that we had a good deal of input. Sorry, I'm laughing at my memo.
Sorry, she was writing.
Oh, sorry. Anyways, so a couple of key takeaways is, and you'll understand the from in my memo, is that we are looking at removing the executive director title from service. What that would mean is that title would no longer be active within our system. So what that indicates is one of two things: either if a person is in that position, so I'm an executive director, I'm the executive director of HR currently. That's why it says for now at the top. My title of executive director is going away, and my position will be evaluated based on the 5 pillars that you guys approved previously. And through that process, my position will be potentially elevated or potentially de-escalated to the director. It also does entail that if there is an executive director position where the duties could be bifurcated out into other director roles, we would consider and will likely do that. So that's the one of the biggest changes that you'll see coming forward. What that does is that reduces a layer of management. This layer of management was put in, and the feedback from the senior leadership team across the board was it was poorly defined, and it hasn't really added any value to the organization in terms of communication, and it's just created a level of uncertainty and bureaucracy that seems to be unneeded. So the second piece is that consistently came up was that there was an importance, it was really important to the senior leadership team that this process was not something that stopped at the senior leadership level, but that we took this opportunity to really dig in and evaluate, what have we done in the past that was successful? Do we need to replicate things that we have done before? Are there things that are best practices that we're not doing now, and how can we incorporate that into our design process? And then the last piece kind of got added, and it's not one of the pillars, but it's kind of a, I would say, a sub-pillar, kind of a support structure, which is the focus will also be on how to build a structure that optimizes reimbursement. Because that is different. You can build an organizational structure that's very effective, but you can also build one that also is effective and optimizes reimbursement. And so we've added that to our goal. So we're confident that as we continue to move through this process, so some things have been penciled in. And I believe Ian's next step is to start to socialize this with the senior leadership team to talk about some of the changes that we are moving forward with and some of the changes that we are still working through to make sure that we have the best structure possible. So.
Anybody have any questions for Chad? When is this gonna take effect?
Well, I think if Ian's on the line, he'd choose. I don't think he is. He'd probably say yesterday, but I'm expect to talk with him when he gets back from his current trip and make that determination. I'm hoping, I would assume that he'd begin to socialize that as soon as he comes back, and then we'd be looking for probably the September or October meeting to come forward with a full plan.
How many executive directors do we have?
Currently, there's myself, Nate Rumsey, and Kim Stout. And Chris Letterman. And Jen Carson.
Any other questions? Shelley?
Chair, so I guess one of my questions is we're hiring a new CEO. Are we gonna go through this again when they come in? Or is, because it seems like whenever there's a change of leadership, there's a change of the organizational.
That's a great question, and I'd like to answer that by saying the goal of us coming forward with the 5 pillars that you guys as a board have approved is that whatever structure ever comes forward in the future, that the first and foremost thought is, does this reflect these pillars that we have agreed are important to us to build our structure on? So the answer to that is, I sure hope not. Because I don't know how much change this place can deal with. And so, what we're trying to build is something, and I've been kind of saying this since early on when I got here, which is we're trying to build something that I call the Bartlett Way, which is just simply best practices combined with some of our unique necessities of being a small rural organization and doing that in a way that supersedes Ian or whoever comes after Ian or whoever comes after that. We have a structure that's viable into the future, based on principles, not based on a person's preferences. So.
This is more a comment to your point that, I think that even though, we're looking at a new CEO and yes, they have brought their own ideas into this, the board of directors is the leadership of that as well. And so I would hope that we would think very carefully before we decide to head off in another direction. And that we're being very focused with how we're interviewing and choosing the next CEO that hopefully then will then carry over. But I understand that. I agree with that question.
I just want to say that I believe that the continuity and of the organization is most important. And we've been in flux for a long time, and we've had some changes that for a long time. So it's really important for this body though to understand that we are a governing board, not an operational board. So if we bring on a new CEO, I think Chad answered that very well. Hopefully we put these 5 pillars in place that it's going to make the standard so there won't be changes. But with that being said too, a new CEO gets to decide how they organize their staff because that's their job. We hire them to run the organization and the operation, and we govern the operation. The fiduciary responsibility number 1 to that. So yes, but on the other hand, operations, we have to keep our fingers on.
Oh, I don't want to get into operations. I just, when I think of it, we worked so hard to get a vision.
So
And then we retool it every 2 years.
I totally agree with you. I totally agree. Shelley too. Any other comments on this? Thank you, Chad. Any new business? No new business? We'll go right to Dr. Walter with the next staff.
Thanks, Mr. Chair. The Met staff met on August 13th. Minutes of the meeting are in the back of the packet in the executive session. There was an action item that came out of the Met staff meeting. It's on page 26 of your packet. If you go to it or if you show it up on the screen, it is a rules and regs change that I mentioned this last month that we were going this direction, and the Credentials Committee wanted to formalize it into rules and regs. They moved that forward. The Executive Committee concurred, and it went to the entire medical staff, which likewise concurred and ratified it. Recall that, especially for bylaws and rules and regs, they certainly do need to be approved by the board. Because it goes into our, essentially it's rules and regs are de facto part of our bylaws that we have an agreement with the board. So it gets approved by this group as well, or at least gets reviewed and discussed and hopefully approved. The specifics are that it's rules and regs that has to do with call coverage. There's already a lot of regulations that pertain to this. For example, there are services that are called essential functions where med staff members have to agree to take a certain number of call days. We're simply extending that same number of call days to other services which are important to the ER and which the ER utilizes, but there have not perhaps been enough people to allow for 31 days a month of call. These are services that the ER uses a lot, urology or ENT, for example, and it simply makes the call requirements for those services similar to those for essential services when there are enough staff members. So currently, informally, when there might be one urologist, he or she often is just gracious enough to say he'll answer calls for the ER whenever he's in town, usually. We'll always try and do that. And this simply sets it up so that if there are more than one person taking that call, that they each at least do 6 days call a month, comparable to the number of call days that are required of folks who are on essential services. So that's the gist of it. Questions? If there are no questions, then Mr. Chair, I think that it would go to you, and med staff would hope that the board would approve it.
Okay, so this is an action item that did not come out of one of our committees. So would someone like to make a motion before we discuss it?
I'll move the board of directors, Bartlett, revised rules and regs of Article 9 of the.
I'll second.
Thank you. Is there any discussion on this? Anybody have any questions or comments? Yes.
So I think we all need to have responsibility as med staff members. I do think I do have a little concern that we don't limit ourselves to bring in that this burden does not limit ourselves bringing in more specialty care at certain times for certain type of things. So I do have a little concern about that. Just because balancing responsibility we have as providers as providers to the hospital, and also our ability as a hospital to bring more services in here, and how is that gonna be impeded by these call requirements? So I don't want it to be. So anyways, it's a delicate thing. I don't but I do have some concern about that.
So can I ask a question? And I guess I just want to give a scenario. So let's say that we have cardiology here, okay? We have one cardiologist that lives here, because I'm not gonna pick on any specific group, so we don't have a cardiologist. And we have a visiting cardiologist that comes here. And the visiting cardiologist comes here 1 week a month. Okay? So does med staff have the right to say, okay, you can be on call that 1 week a month that you're here? Or could they change the call to the week that he's not here? Look, we got that week covered. We need you to be here another week. Can that happen?
Med staff, the call schedule is kind of under the auspices of med exec. And we deal with situations like that frequently where we have to kind of figure out how to make it work. So med exec would be expected to make that work to the satisfaction of the person who wants to be here for a week a month. We understand that you have to be practical, and we're not trying to preclude people from coming up. The main goal is to keep it fair. If you got a urologist who's taking, 27 days of call when he or she is in town, it seemed unfair to think that you might have somebody who wanted to come up and do 1 day of surgery, but not share a little bit of that call burden. So we made it similar to essential services. But yes, to answer your question, med exec would understand that we would work as hard as possible to make it work out. And we would think that that was our responsibility to make it work out for somebody who wanted to come up and do a more limited amount of time.
So Dr. Jones, I guess my question for you would be, would you be concerned with that scenario?
Not with that scenario at all, but I can see other scenarios that I'm not quite, I guess I'm not quite certain how that it would not. I want to make sure that we're open to provide some subspecialty care. We're weighing two things, like let's say that we have a urologist that specializes in prostatic, or in robotic assisted prostatectomies that wants to come up here. And so there's another urologist. Are we going to be limited ourselves to that person because of this type of call thing? Or let's say we have an orthopedic doctor that specializes in spine surgery that was willing to come here. Are we going to be limiting that person from showing up here based upon this thing? That's one side. The other side that I see, okay, we have someone at a different clinic that a different healthcare organization that wants to have an ENT doctor come up here, and they want to work for 3 days and do a bunch of stuff, and they're not going to take any call, and our poor ENT doctor is sitting here. So I see both sides of it, but again, I don't know. I see pitfalls with both ways, so I just I don't.
Walter, and then Sean.
Through the chair. So if someone came up and did 2 days of surgery, then they're not required to do a full week call, correct?
In this scenario, yes, they are.
Through the chair. So the way we anticipate making this work is we say for specialties which are frequently called by the ER, we don't think of gynecologic surgery. The ER would call the gynecologist. In general, they're not frequently going to call the gynecologic surgeon. So the gynecologic surgeon would not be covered here. If you had a generalist, orthopedist who was doing general orthopedics in Anchorage, but wanted to come here, and maybe he or she was going to do hands here, but really could do general orthopedics. We have traditionally said that all the orthopedists, including our back surgeon who was here 6 years ago, had to share a call. So if the specialist is able to do services which would generally be called by the ER or utilized, then we would anticipate that particular kind of general orthopedic surgeon would indeed need to be on call, but not at least the way it's written. not the gynecologic oncologist who's not going to be called in frequently. We also, what we want to avoid is we want to avoid John Huffer, hypothetically, the urologist who currently is doing 27 days of call, which really helps the ER because they're often calling urology. We don't want to have him aggrieved because somebody's coming up and doing 2 days of urology call, or 2 days of urology, and have John Huffer say, well, fine, I won't take ER call. You know, we want it to be fair so that folks, if they're going to be offering the same types of surgery, they have to be doing at least a modicum of call coverage for the ER for those specialties that get called frequently. That was the thinking of the medical staff. It benefits Lindy and Lindy's staff to have John Huffer. He's not literally taking call, but he's available 27 days a month. That's very beneficial to the community. Not beneficial if the urologist comes up, maybe does a few extra cases, you know, which we like, but really is irritating the guy who's here enough that the guy who's here says, you know, that's fine, I just won't take call. If this other person's coming up and not taking call, that's what we want to avoid.
So who delineates which specialty has to take call or not? So you actually talked about a gyno, okay?
Yeah.
So the gyno is gonna come in and do some surgeries and then they leave and then something goes south and so the regular gynecologic doctor is gonna come here and look at them before we probably ship them out or whatever. And they're on call, but the gyno didn't have to do any call, is that correct?
That's correct. We already have rules and regs in on the prior page, which shows who's considered essential services. But in general, the bylaws and rules and regs kind of delegate to the executive med exec, you know, kind of the keeping of the call schedule. So it has to be practical. But if there are enough people around to cover a service that the ER likes to consult, then, for example, with your essential services, we require those folks to be take a certain amount of call. Recall that when before Dr. Hightower started his practice here, he would come down and do surgeries, but he wouldn't leave town for a week or two because he wanted to be responsible for his patients. So you can't, the bylaws would also specify that if you are going to be doing surgery here, that you can't leave town unless you have call coverage arranged. So unless you've got somebody who has specifically agreed to see any post-operative patients who are having complications, you can't just come down and do an itinerant day and a half of surgery and then not have it. And that's already in the rules and regs somewhere else.
Well, as I'm trying to take this all in, it looks to me like there's no way around the fact that there's a huge element of trust in the med exec to just practically make this work. There's no way we can craft some kind of flow chart as to how to make this all work without just some trust to deal with the practical trauma. So I think I'm comfortable voting for this, aware that this could lead to trouble down the line, but I think the history, as long as I've been here, is that the med exec has made these things work. So I've got that trust.
Yeah, and just to be clear, I mean, med exec has approved this language, right? Yes, right. Yeah, so.
And I just want to talk about just for a second too, that Ian did talk about this with us last month as well. So this is something completely new to us.
So med staff beyond just med exec.
Yeah, the broad med staff, sorry.
No, you're right, and also credentialing too.
And as the cover memo says, administration approved the revised rules and regs presented before. So Mr. Warden was comfortable with this when he presented.
All right. No more discussion. We have a motion on the floor. It's been seconded. Do we have any objections? Seeing no objections, motion passes.
With that, the
Med Staff Committee report is finalized.
Some details in the executive session.
Thank you, Dr. Walter. Committee reports. Yeah, we'll start with you.
Okay, so we went through a couple of policies. We didn't just rubber stamp them. We really went through them and we looked at the logic. And we focused on a few words and we looked at that pretty consistently. So these policies were revised based on our discussions, and I think that was a useful discussion. And hopefully that'll have some lasting effect as we look at other policies. The other thing I'd point out, there's a handbook that was prepared, not in policy language, but in just plain English, and that looked really, that was well written and easily digested. And so I really want to compliment Phil for putting that together. So we do have two policies that are up that we're suggesting that the full board approve. Before turning over for that, I would say also that we received some information from legal in executive session, and we felt strongly that should come to the full board should be advised of that. And so I hope there'll be a report in executive session.
Sounds great.
So there's two policies that we've offered.
So we have an action item that came out of committee, the action item has been put forward and it's been seconded. Do we have any objections? Do you have any comments? Seeing no comments.
Comment is that, if I may, Hal went through this with a fine-tooth comb
We did.
and made all the words jive according to policies. It's so great.
I actually read it and it actually has some stuff. Thank you, guys. Thank you very much. So seeing no objections, no comments, thank you all for the committee's work.
Oh, and thanks to Gail.
Yeah, Gail. Next, finance.
Page 46 of the package is minutes from what was a record amount. You'll notice that we adjourned at 12:29. So exactly 30 minutes long. But it is important, I think, to point out the fact that we had in June another month of net income. And those were, unless I missed it, I went back to 2020 before I found 2 months in a row of net profit. So that's I think notable. And we'll be hearing later about a third month of net profit. So that's commendable. And looking at those results, we're seeing improvement in the top line and control in the expenses. And so we're, it's good to see. Hopefully we'll see more of it. I don't have anything further, kids.
Thank you, Max. That was the fastest finance meeting ever. Appreciate it.
Made up for the other ones.
Yeah, that's a fact.
So, you guys want to take a quick 5-minute break? Use the restroom real quick, and then we'll go right into the. Break the last one. Thank you guys for coming back on time. Next. So Ian's not here today, so Joe's gonna be filling in for with the administration report. We're gonna just take one more second for Max to come in the room. One more. One minute, Joe, and then we'll have you go ahead and speak. Okay, Joe, go ahead.
Jump into it? Yeah. So before I jump into Ian's letter and report that he submitted, I want to go over a resolution 01 from back in the June meeting. So in that resolution, administration was asked to bring forth in by August 31st, a report of what we were doing with the BOPS program. So what was asked is just communicate goals for efficiency and improvement of services. So there's nothing in the report today, so it's more of a verbal. So what we're doing for the BOPS program is we're looking at all the efficiencies in the program. We've had some staff turnover, so we have one less clinician that left during the July period. We're all down one provider as well, so we're down to the 5 required providers for the MHU at this point, so we're down to those positions. We've set a baseline for measuring productivity and efficiencies for all the providers in the program. So measured the baseline, and now we're in our kind of measurement period post baseline, which actually ends this Friday. And so when we got that report, we can analyze that, look at changing the program and making amendments to be more efficient. So that's just the report for BOPS at this point. We'll bring back more information in the September as we get past this first period of measurement. So diving into Ian's letter, I don't think I can do justice. I'm not quite the talker that Ian is on a monthly basis. But his letter goes over the accountability of the organization and what he sees as he's being held accountable for in his role. So I'm just gonna go over the high points of the letter as I see them. I discussed these with Ian, and he told me to pick out the high points. So bullet number 1, it goes over the strategic and development. And he sees that as 90% complete at this point. The Bartlett board did complete the high-level strategic plan back in November, and management went through and kind of put together tactics and how we attack all these strategies to improve the hospital at this point. And with that, we've implemented the A3 process. So that's where we have a quality improvement process where all department directors are engaged. And they have different projects that they have to work with within the strategies that we see and within their department. We've met 3 times up to this point quarterly. We've gone through 92 initial A3s that have been divided between strategic and departmental. So the next steps for this is kind of refining the process. We are still tweaking it on a quarterly basis. We're getting better and better with each time. Department directors are getting better at leading their A3, being accountable to their goals. So they're adding measurements, assigning people to complete those at this point. Moving on to number 2, which was the non-core entity disposition, which he sees at 70% complete. So the highlights in that one is we went through the core, non-core program evaluation through the budget process. With the non-core being seen as ABA, BOPS at the time, crisis, home health, hospice, and RRC. You know, BOPS went on to be designated as core because it's attached to the MHU. The ABA program closed effective June 13th, 2024. Crisis service, after not being funded by CBJ, was closed effective July 16th, 2024. With the last 2 remaining with home health, hospice, and RRC, we're having a meeting with Assembly Finance Committee on September 4th to discuss funding of both those programs. Going on to the next bullet, which is core entity sustainability. This is where a lot of management's work has been focused these last few months. So some of the highlights on that, we have got the application for critical access hospital. We've requested a waiver from the state. We actually got contacted back on the initial application with a request for more information to substantiate the proposed savings that were in that application. So I submitted the 3 different ways we measured that and how we substantiated those measures. So I see that as a step in the right direction. So they're looking at the proposed $5.7 to $5.9 million in initial reimbursement. And so that's a step in the right direction on that application.
Joe, that must have happened since the finance committee last Friday.
About 3:30 this afternoon.
Oh, okay, just, yeah.
That's brand new.
By noon, you hadn't heard, right?
Yeah, I heard.
And they've asked for the reply by, is there a time, return time?
I submitted all the information they requested.
You already have.
So I had that done by 4:30.
What took you so long, Joe? And did they give any indication of when we'd hear back from them, or is that?
There was nothing indicated in the letter, so. It was an email, it wasn't an official letter, so I submitted, I see it as positive because it had all the commissioners and deputy commissioners actually on the email. And so there's a lot of people involved in DOH at this point.
It was a short email, not just a few questions, or was it?
It was just on how they wanted substantiation of the savings or the increased reimbursement from Medicare. Which we had three different people. We had a report from Mike Bailey, a report from DZA, and a report from Bradley and Associates, which was another one. So we had three different people look at it and they were within 150,000 of each other on two different years. So all that was submitted back to them with how we go today.
It's great.
That's really great.
Going to that, another of the highlights was sustainability. We had resubmitted the 22 and 23 cost reports, and that resulted in an additional $1.1 million in Medicare reimbursement. We received the first another back, waiting on the second payment. When we look at the efficiencies, the kind of the cost savings we've done, we've reduced traveler expenses by 700,000, FTE savings by 1.9 million, and contracts by 550,000. This is achieved through, our position control, our FTE committee, contract management, and IT governance. We continue to work on, these on a weekly basis, trying to control our costs. Moving on to strategic growth and affiliation. So some of the things that we've had motion on is we've continued to work on our women's services, both in oncology, where they've brought on a third surgeon into that group to continue to do surgeries. We've had discussion with med-onc providers at this point that's expressed interest in the community to help either replace our current med-onc providers or add additional days. We've also had expansion in diagnostic imaging with the new CT and the new imaging we can do, as well as mammography with the dense breast images that we can now take. So that's kind of a summary of Ian's letters. He went through the pieces that he did. To add on to that, Max had indicated that we had that third month of profit. So we just finished the July financials just recently. It took a little bit longer because we held June open to get all of that, cleaned up. But for the month of July, we're looking at a net margin of $1.35 million for the entity. And so that would be 3 months of profit. It needs to be taken into consideration that the 3 months, preceding 6 months, we had $8.3 million in losses as well. And so we need to make sure that we can get the good months need to be able to offset the bad months so we can get that 3% margin overall. But we have made strides in the right direction. We're not quite there.
What about year over year, Joe?
I haven't done that assessment yet, sorry.
July to July.
July to July. Well, last July we had we posted net losses, almost $1 million to start the year last year. So we start the fiscal year FY25 in a much better place than we did last year.
Turnaround this year.
Yeah, year over year. We did have, revenues are strong, but like Max indicated, we've kept bill control expenses month over month the last couple of months. So it's been pretty steady on the expense side.
Just from the 30,000 foot view. It sounds like we got some reimbursement from Medicare reports and things like that. Is that substantially why we've had these 3 months in the black?
That impacted June the most. May and July were predominantly driven by high revenues with keeping expenses flat.
Yeah, it's a good question Dr. Raft brings up, and I know you don't have the numbers in front of you, and I know you appreciate that. When you looked at July 23 to July 24, there was about a 25% increase in the top line.
Yeah.
That wasn't driven by any one-offs.
There was no exceptions to the financial report this month that I could indicate.
And a lot of that is volume driven, our volume driven increases, correct? Better ADC at mental health and
across all the inpatient units.
Yeah. And at the same time, been able to manage staffing costs at largely the same level year over year, right?
Yeah.
That's really, they're healthy, kind of things that you would hope to see in a business that, are sustainable, I guess.
So basically what you're saying is we're making $2 million and we're only spending $200,000. Is that correct?
And Joe, would you also touch on the core on Bartlett versus, because I think Wildflower Court's part of that. But the July results, you also saw a positive in the core entity, correct?
Yeah, the core entity, there was a positive, so there was positive lines for the hospital as a standalone entity, and for Wildflower Court as an entity. So that includes, Bob's Hospital and some of those other programs in there. We continue to see losses, and the ones we see losses every month. Bryce has posted a decent loss. RC had a loss to it. I think those are the two that popped out was the biggest losses. Home health and hospice, they don't see big losses because I don't assign contractuals to them. But once I did that, there'd probably be slight losses on those, but they have made improvements in those two as well.
Dr. Rosser.
All right, another broad question. The Wildflower Court, I know we just got a bump in our reimbursement, right? And is that potentially going to go higher, or is that a sort of where we need to think about our income for that?
Well, when we filed for their most recent exceptional relief payment, they have actually locked in that amount until we get our finalized rate through the cost report process. So we'll be at that rate, which is, they'll increase it with CPI next year, but we have that rate for 2 more years before they give us our first full rate, which we'll know what will look like after we do this cost report here shortly. So I anticipate it could potentially go higher just based on initial estimates, but I don't want to promise any numbers. Yeah.
So, one that we've talked about the success of, we're 90% complete with the first bullet. The A3 process, one of the things that we had talked about, I don't know, a couple of board meetings ago, maybe, I don't remember exactly when it was asking leadership to bring back to the board success stories. I know that you read the staff and the departments regularly get together and report out on the status of those selections, but it would be great for us to, and we can go to the downstairs to the board, the big board, with everything on it, but it would be great to have a report out in this body. And it would also, because this is a public meeting, it would also go out to the community, so.
I think we can throw something like that together. We went through this, exercises, completed A3s actually through the process. So we have them kind of itemized the rest of that.
So through the chair, so that actually is something through the Joint Commission that you are required to hear through process improvement. So we are working on that through our leadership team of a new way, because before COVID, we used to have a lot of reports being brought to the board. So we are working on that as a leadership team to bring those projects back to the board for hearing. So whether it comes through the quality committee or directly to this full meeting, that will probably be determined in the next quarter.
Okay. I'll be interested to hear the results.
I just have one comment from boots on the ground. I mean, I think the attitude of our frontline workers has changed, and they're much more getting to yes, bringing people into our ER, getting to yes to make sure that they're admitted and not being medevaced out. So I really think that we need to commend the hard work that they've done to really, they're invested in this hospital and they're working their butts off to make sure that all those opportunities that we can to provide care, we're meeting them. So I'm very I'm proud to see that.
Yes.
I appreciate the work that you guys are doing, but it would be great at some point, whether, as you said, whether it comes through the quality or through the leadership's reports, to just pick 1 or 2 successes to report out to the broader group, just to give a pat on that.
And through the chair, what we would like to do is have the team that has done the work come and do the report. I think that is more important for you to hear the people who've done the work.
Perfect.
Thank you.
The last bullet I just have here is we continue to work on the PES process. So that was something that was also brought up during the resolution, because now we continue that service to the community while also trying to integrate it with the MIH program as well. So we've had several meetings, last two, I think we've had a lower attendance. So we've kind of have a plan in place, but we need to pull the group back together to kind of flesh it out, but we're getting close, I think. We started working with Jeremy and there might be some limitations in how we were able to work with him based on licensure, so. The plans kind of shifted over the last month, but I think we're getting close to have a final plan in place that we can present to the group and have a move forward.
Through the chair, that's for the mobile crisis, also mobile crisis response team with CJ.
So we'll have hopefully more information on that.
Yes, we started working on, because of the flood, some of the meetings and some of the players got changed, so that kind of got delayed, but we're still working on our side of it and going through emails. Some of the CBJ folks were out of town. On our side, we have continued to bring on PES clinicians. Unfortunately, they are contract labor. We are working on a job description to consolidate, to include, to incorporate the major piece, since the current job description we have doesn't include responding in the field. So we worked on that, and there's been several sets of eyes on that through the behavioral health round to look at that, to make sure that that's okay. So we should, once we get everybody's comments and get it cleaned up, to be able to post for that position for a Bartlett employee as opposed to having to use contract labor. And so we are moving forward. We'll be reaching out. I reached out today to Joe Missler with CCFR at MIH to see if we could set up another meeting to see how we could move forward with training, get the policies and procedures in place so we can starting small, like 8 to 6, I think, is the hours that their MIH is available. 7 days a week, and that might have to go down to 5, but we are still moving forward. It's just stalled a little bit because of Mother Nature. So as soon as we have a bigger update and more information, we'll forward that to you.
Dr. Jones, you're still involved with this.
Joe, question about the September 4th meeting. Is there going to be, will you have a part of that? Will Bartlett have a part of that? Or is that really between Katie or the city manager and the assembly finance?
Yeah, we'll still continue to have a part of it. So we're gonna go over, they've asked to go over RSC, what the difference between a 3.5 and a 3.1 service level is. So we're gonna go into detail on those. That's what they've asked at this point. And so that's what we're gonna focus our kind of presentation on. That's what Katie had given me today. Does that answer your question?
It does, thank you.
Joe. Okay, yeah.
You can read the report, you probably already have, but as of today, Wildflower Court has 51 residents in Wildflower Court. We have 4 pending referrals / admissions. Hospice has 3 on service with a length of stay of 72 days. And home health has 21 patients on service. I will say in the report, you will see that the Director of Home Care Services, Heather Richter, has been very active over the past 5-6 weeks. Getting out, providing educational in-services to physician clinics. She's been to Search, she's been to Valley Medical, and she has came over to Wildflower Court and in-service the staff on hospice. She has worked with Erin, and they have several things in the work, but we now have a home health and a hospice Facebook page. And the goal on that is to continue to put out education and information as it relates to those services, who meets criteria for admission into those services, that type of thing. And she's hoping to get it to even become a frequently asked question and answer type
page, for lack of better words. Otherwise, on home health and hospice, unless you have any questions, I'll move on to Wildflower Court. I always have a lot of information on Wildflower Court. Again, we have 51 residents on service. We are a 61-bed facility. I'll remind you that we're 61 beds. We are close to capacity with the staffing that I have at the number that I'm at right now. It always depends a little on the acuity of the residents that you have in there. But on a positive note, we did employ 8 new certified nurse aides that came out of Bartlett's growing their own program. They're currently in their orientation phase at Wildflower Court. 2 more will be taking their exam in about 2 to 3 weeks. So hopefully we'll have a total of 10 new CNAs just within a really short time frame. We also have, we actually have job offers out to some CNAs. I will say they're out of state CNAs. They're very interested, but we'll see if that materializes or not. You may know more about that than I do. I don't know. We do have 10 CNA travelers. So as you know, we're bringing 8 and hopefully 2 more will test. So as their contracts are expiring, they're going away. And we also have 6 licensed nurse travelers still at Wildflower Court. We don't have any licensed nurse applicants at this time. So, one important thing is the facility assessment, which I think I spoke to back in about May or June, that Medicare CMS had put in new requirements related to our annual facility assessment. It's heavily weighted on our staffing. I attended a webinar today with one of the ladies from the finance department, and it was really centered around our value-based purchasing and how it's going to impact reimbursement. And it was centered around nurse attrition, turnover rates, and on our nurse staffing. And they're going to be heavily measuring that. But the facility assessment, again, it's circling that. It should be coming to the board for your review, hopefully next month. It's a big packet. So come prepared with your questions and hopefully I can answer them. And then it will be going to the quality committee of the board first. So go there with it. Our numbers, as you can see on our average daily census, it is starting to rise, which I predicted that. At July, we're at 49.84. I feel like August is going to be 50, 51, somewhere in there as an average. And I hope to continue to see that flatten out and continue to rise and us stay in the mid 50s. That's my hope. Any questions?
No, I do want to talk just quickly about the CNA program and let you know that I have employees that work for me, and they have gone through work for there and gone through the CNA program and now are employed for Wildflower Court, which I'm super excited about. And not only that, I have a friend that I had a phone call with today that his wife has worked for Wildflower Court for 13 years, and that she actually quit because she got accepted into the LPN program, and she's super excited, and he was super excited. You know, he's like, my wife's back in school, she's super happy about it, and she can't wait to finish and come back to Wildflower Court. So
that's what we want to hear.
Yeah, I just think it's really important that you guys should celebrate that successes and what you've done with the Grow Your Own program. So thank you, everybody that's been involved. I know there's a lot. I see Jen's on and Tweeters there too. So thank you guys all for that.
And through the chair, our LPN program just started and we have 9 LPN students in it. And we have our UAA program, which is 1 students that just started this fall. And our Nightingale program, I believe there's 4 students in it. So we have a lot of students coming in for our Grow Your Own program. So Jenny has done an amazing job of getting our pipeline, keeping our pipeline filled.
Thank you, Jenny. Thanks, Jeff.
Kim, I'm excited to see that you've got the in-service training about hospice and home care on the schedule here. That's great. You know, we've heard from you and from others that that's important to the, you know, utilization for those services. And it's the thought that it's going to be recurrent. I mean, are you hoping to get back in there, you know, with these folks like every 6 months or what?
Absolutely. I want to be, and Heather does as well. We want to remain as visible and as we can without wearing our welcome out.
I see the 3 that are listed here, but I don't see family practice.
Dr. Malter, would you like to?
Search Wildflower Court and Valley. You'll take care of that.
We would of course be happy to speak. Heather Quigley been out there before, you know, maybe not this most recent one, but Dr. Peterson and Heather presented this previously.
Just giving you our time. That's great. Thank you.
Thank you very much. Does anybody else have any more questions for Kim? Thank you very much for your report. I don't see anybody from legal here. So we'll just. Maria. Maria.
It's Maria.
I know, it's like, I'm like, I was talking about legal and you're right on the Maria.
Thank you. I have the report on there, but I do have some reporting to do on the event on Saturday. The donor appreciation fundraiser. And the auction revenue, we saw about 30% increase in that, which is very happy to see. From $10,000 between both auctions to about 13 this year, so that was positive. The rest of the news, we saw 85% decrease in sponsorship revenue from 33,000 last time to about 5,000 this year, and 47% decrease in same-day donations. 6,800 in last time, 36 this time, and that we've talked about the reasons for the decreases in sponsorships and donations. Talked about that, so hopefully we'll see some stability coming through with the hospital, you know, stabilizing and good things that are happening. It's important to get that information out to the community to get some confidence back into what we're doing and donor confidence. I think the news are great. We just have to work on getting it out there.
Through the chair.
Yes.
I was trying to grab a hold of those numbers as they ran by. Did you say $5,000 for this year? Is that the calendar year or is that our fiscal year that just started?
No, it's the event. I measure
is it?
the event. So I keep records. In 2019, sponsorships were $23,000. In 22, there were almost 33, and this year there were 5. So we've talked about that, briefed this before, that it's serious.
Okay, thank you.
That kind of translated the same way to same-day donations. That's people at the event writing checks. So I'm not surprised. I think seeing the numbers and quantifying them makes it a little more real for someone who's not as everyday as I am. This is a really good measure, and might be a little fluctuation sometimes after the event, but I don't expect a lot. So that's sobering. It's closed. We're moving on. Good things are happening, and hopefully donor confidence will return with new things. So for the foundation, this is the last big event that we have for the year. I've been talking with Erin and Heather for some event for hospice, perhaps in the December timeframe. we have to balance that because we also have the employee event for Visit with Santa, tree lighting in December. But fundraising wise, it'll be a hospice event in November. Still planning it. Light up life. So that's the next calendar fundraiser. And those are all the good news I have. Any other questions?
Anybody have any questions for Maria? Nope, seeing no questions. Maria, thank you.
I do have a comment. The event was fun. I think it was just Hal and I that were there, if I remember right. I outbid Hal, but then I got outbid, so. I mean, I'm
Healthy competition there and some items.
The fig was good. Sorry to just interrupt there. Fig was delicious. I'm still eating, I still have some more fig.
I do have one question, Maria. What was the feedback you got when the few board members met with your, some of the donors?
They were appreciative of the information that was provided, although a lot of it had been out in the news, but just having board members be accountable and sit in front of them eyeball to eyeball and say, yes, this is, I understand what you're saying and I understand where you're coming from. That was very, very, very helpful. I mean, I think if we can think of other ways in providing more feedback to the community and that translate to donors, not necessarily those one-on-one meetings like that, but that one I felt was critical and we needed to have it with those donors at that time. But I did experience this time on some of the sponsorships requests, people pulling back their sponsorships.
Yeah.
And we've talked about that. It's concerning.
Yes.
The level. Huge numbers. And it's a very giving community otherwise. This is let's wait and see.
Thank you, Maria.
Thank you, Mr. Chair. After the glacial outburst flooding, that dominated any of the assembly meetings. Some of them got canceled or pushed back. I can answer any questions that you guys want to know, like where the city's at and what our actions are, what the state or federal is working on. But I have the single best news I heard yesterday. Last year, when the Aquahap event happened, the Army Corps of Engineers wouldn't even answer the request from Juneau. They just wouldn't answer us. They said 30 homes, the flood, no, that's wasn't even on their radar. They wouldn't even respond. With it happening, the one silver lining of this whole thing is that it happened on the anniversary date. And now it is the #1 thing for the Army Corps of Engineers to study. That means they're going to study it for the next 5 years. So that's not a great immediate answer, but it went from not even giving us a call back to their #1 studied disaster that they're looking at. When I heard that, that gave me the confidence that the federal government is taking a different approach to this event. The CBJ has done, last year we did everything that was legally within our power to do. And then with the mayor and the city manager reaching out, I mean, we did every single thing that was available to us. And this year we did it and had even the emergency operation set up before the event even happened. Like we knew it was happening, they stood it up. Our city could write the book on how you do a disaster response for something that is happening. What they did standing up the EOC on the 5th and the 6th was, I mean, just textbook. You just couldn't have had a city stand up an operation better than that. Unfortunately, the community is pretty upset because they're like, why didn't the city do anything? Well, because the city has no control over the federal land or any of the actions that are going to happen. We can have discussion and meeting, but until it got that Army Corps of Engineer attention, our hands were going to be tied. And now we are actually going to be able to look at some of the things that we could do. And those include levee system that could potentially make the lake bigger, absorb more water. One of the things that was initially discussed was additional channels to allow more water to exit once the river level got so high, make some additional channels. It's the one other city on the planet that has actually successfully dealt with glacial outburst flooding is a city in either Finland or Sweden. And it was 1/10 of the scale of what we're dealing with, but that's what they did was they had extra routes to drain the water. And so we're looking at some very real things like that. When Senator Murkowski was up here, she's like, well, what can we blow it up? So last year that was a joke. This year, the senator says, what bombs do you need? So it's a completely different picture for the Yakahop, and that's what our primary focus has been on. However, on the Public Works and Facility that happened the morning of the 5th, we had our first touch on the emergency department, our first look at it. And we did move it on to Committee of the Whole. Assembly members are going to have some questions about it. They were wanting the funding issues. So if you have a favorite assembly person, if you want to give them your 2 cents on the emergency room, we are going to be discussing that in the future. And 2 of my subway employees have recently been signed up for that CNA program. And I just finished their reference checks with it. So give me 2 of my guys. Right, Alice. That concludes my report, Mr. Chair.
Thank you, Mr. Bryson. Anybody have any questions for Mr. Bryson? Thank you very much. Already my report, which is short and sweet. I was able to meet with Ian and Joe several times this month. Deb was with me, most of them, and Max met with me with Joe too. So good information. But it's all been disseminated in this report here. I thank you, Max, for talking about last month. You guys requested, or we talked about some of us meeting with key donors of the foundation, and so Max and I and Deb, we were able to like Maria said, eye to eye with them, and I got to tell you that. When they came in, they were concerned. They had some really good concerns, and I think that we were able to honestly talk to them, and they really understood better where we're coming from. But still, like Maria says, they aren't totally on a wait and see, and we're seeing that by donations. I also do know that right now, because of several things going on in our community with the glacier outbursts and stuff, there's a lot of resources being directed to other areas. So I think that could be a little bit of it too for why the event didn't capture as much donations as we would like to see. So with that, I think does anybody have any questions for me? No? Okay, we'll go ahead and put the calendar up on the screen here. Then we got a lot of vacations in front, so we see Saturday the 7th. Has been moved. And
What time is that? That day is that now?
It's gonna be on Friday, the 6th at 8 AM.
okay, so it's going to be moved to the 6th. So we'll do that, and Chad's going to probably have some more information on that board meeting too. So expect that board meeting to go a little bit better. Finance, I know that we worked through that in finance, so I think the 12th is all good. Is that right, Nick?
Yeah. Planning also remains.
Oh, planning, I'm sorry.
Unless committee members have a problem with that. I thought we did discuss it at the last meeting.
Since we're meeting in the morning, I think I'll be there. I know.
And that was my thought. We might as well just roll into it rather than scheduling another day.
So we'll leave planning on the 6th, and you guys can just go right to it.
Indeed.
Quality of the 19th.
Meeting quality of 19. Oh,
What time are we? 3? 3 on the 19th.
3:30?
3.
Three thirty.
3:30.
Don't you usually do it?
Yeah, 3:30.
3:30 on the 19th. Does that work?
3:30?
Yeah.
Okay.
Who's on the quality committee? And you guys are gonna be here? You're not gonna be here?
I think I'll be able to call in.
Okay.
Yeah. And the world tour doesn't start till some other time.
I won't be here for that.
Probably, yeah. Thank you.
I'm
Writing it down right now.
I have board meeting on the 24th, so there's no changes to that. With that, we get a motion to approve the calendar,
I move to approve the calendar as amended.
seconded by Dr. Raster. So. Any discussions, no objections? All right. With that, we are going to go into an executive session, so we'll take a quick 5-minute break. Oh, hold on one second, guys. Hold on one second. Board comments and questions. Is there any board comments and questions? I missed that usually. Okay, no board comments and questions. We're fine with her here. Session here. Al, you want to take us into executive session?
I don't have the text in front of me.
There you go.
Yes, Mr. Chairman, I move, the Board of Directors of Bartlett Regional Hospital move into executive session to discuss several matters, including those which by law, municipal charter, or ordinance are required consideration of records that are not subject to public disclosure, specifically the credential report, medical staff meeting minutes, patient safety dashboard, and union negotiations, and to discuss possible Bartlett Regional Hospital litigation, specifically a candidate discussion of facts, litigation strategies with Bartlett Regional Hospital, the city attorney, and building compliance matter with the Hall Ranger attorney. And I ask that you be allowed to choose which staff to include in the meeting.
Thank you very much. Dr. Astor seconds it. Seeing no objections, we'll go to executive session. We're officially out of executive session. Hang on one second and Hal will make a motion for us. Okay, we're good to go.
Mr. Chair, I move that we, I would note that we received direction on the union negotiation while we're in executive session, and that we accepted the credential.
All right. So we accept the motion is to accept the credentialing report.
Oh, second.
Second, okay. No objections? Credentialing report is accepted. That comes to the end of our agenda. Everybody have a really good night. Thank you for everybody's volunteer.
And I just want you guys to not blow off this morning. I down